Okay, hi, my name is Amanda Small. This is my video summary journal for the short study abroad trip to the UK and Ireland. First, I'm going to go through my self-directed learning objectives and kind of talk about how I feel that I've accomplished those. And then I'm going to go through the 9 different course objectives and then talk about how I've accomplished those as well. So, one of my first objective was to learn how the pharmacy class of drugs worked. We had some readings to do for background information on kind of what drugs were included in the pharmacy class of drugs and a little bit of background on how it works, but I always find that there's a bit of a difference between the theory of how something is supposed to work and how it actually ends up being practiced. So I didn't really get much exposure to this in Ireland. We did talk to a community pharmacist who said that a lot of the stuff was behind the counter, that you just had to kind of consult and ask a few questions and then document that you had a conversation about it, and then you'd be able to sell the product. In England, I was actually kind of sick and I needed Sudafed, so I got to talk to a pharmacist firsthand about the product, and I requested for a Sudafed, but he saw one of my medications interacted with it. It was a theoretical one, and they were kind of pushing me to get an herbal product. So thought that was kind of interesting, because in the United States we have a whole bunch of herbal products, but I'm not really sure if pharmacists really push them or know much about them. Whereas this pharmacist was actively discouraging me from Sudafed and recommending something else. So, in England, they have very few products out on the shelves of the pharmacy. Most of them are behind the pharmacy counter. They can only be obtained after an interview with a pharmacy technician or pharmacist. So the pharmacist is usually back in the back doing the clinical checks on the prescriptions, and the technicians are the ones usually managing the registers, which is similar to how it is in the States. So the technician kind of asks a few key questions of, are you on any other medications, do you have any allergies, basically to kind of triage and filter out patients that obviously can use the drug or obviously cannot. From there, they kind of report back to the pharmacist, say, okay, this is what this person answered, and then kind of the pharmacist asks any further questions and assesses the true appropriateness of the OTC product. I think that's kind of similar to how we run self-care in PharmUK therapies 4 and 5, but it's kind of different in that if you tell a patient in the States you can't buy that product because it's not appropriate for you, they can still buy it anyways. Whereas in England and Scotland and Ireland, you can't, because you have to get it behind the counter, which I thought was really interesting and probably better. So my second objective was opportunities for pharmacists to be clinical and on the healthcare team. So in England and Scotland, they have accuracy checking technicians, and that is in most upper level hospital pharmacies and most retail pharmacies that we've seen. Obviously, what we have seen was not a representative sample of the healthcare system, because I feel like they were trying to show us the best of the best. So I take the information that I have with a grain of salt. But at these institutions, due to the prevalence of accuracy checking technicians, hospital pharmacists have a much more clinical job. They're reviewing the drug charts alongside the doctors, and they can be independent prescribers. So they can kind of have a healthcare team centered around themselves without involving the GPs. So they have a lot more advanced practice and clinical learning that occurs once they're actually pharmacists, which is different than ours is much more throughout our curriculum. So role of pharmacists in managing patients in a critical care setting, and role of pharmacists in patients helping with antimicrobial stewardship are kind of along the same lines, I think, of that it's kind of similar to the United States, and that pharmacists obviously have opportunities in both of these areas to perform drug use reviews and adjust medications based on appropriateness. So it's really important. Sorry. One of the interesting things I thought was that like they don't have as much of a formalized structure for doing these reviews and like or becoming an antibiotic stewardship pharmacist or critical care pharmacist. They don't have like a residency like program. It's more of like you get hired into a hospital for like pharmacy, and then they have a need for an antibiotic pharmacist, and you're interested in that, so you kind of offer up your services, and it's kind of very learning on the job. They have a bit of a heavy emphasis on the antimicrobial stewardship, simply because it's a huge cost saving for the NHS. Huge emphasis on obtaining cultures and streamlining therapy, and decreasing resistance. I think because they have so much more of a systematic view of if I use this antibiotic inappropriately in this patient, it can cause resistance, which can then affect this patient, and then we also have to pay to treat that patient. I think it's a much better system in that it's kind of looks at it every way in general, more of a public health kind of perspective. So I thought that was really cool. How they teach pharmacotherapy was my fifth self-directed learning objective. So they don't really teach pharmacotherapy is what I found. Nothing in their coursework is really kind of analogous. Most of the clinical knowledge seems to kind of come after they graduate. After you graduate, you do your pre-registration year, which is like your 1 year of clinical experience. You can do it like in a hospital, for example, or a community pharmacy. So you do it in a hospital. Then you become a band 5 pharmacist, which is like your basic entry-level pharmacist, and you get a certain amount of pay associated with that, and a certain amount of responsibility associated with that. And then you kind of move up the band system to advance your career, which comes with increasing pay, increasing clinical responsibilities, and then once you get to, I think it's 8, you get more management responsibilities. Band 6 is you're working on a clinical diploma. That's like a 2-year postgraduate kind of diploma, which is like half schooling, half clinical, like work experience in a hospital pharmacy. And you kind of, it's case-based, you learn, it seems very, very similar to our pharmacotherapy courses, which is kind of sad that it's like you have to be that far in your career in order to get that sort of experience, but at the same time it's cool that they kind of offer that as an experience. And then that's another, like that's a diploma, so you can then use that to kind of market yourself as well. I've got this diploma, therefore I'm more qualified for this job, and you get a higher pay raise and stuff like that. So it's kind of interesting. We didn't really get too much detail on the clinical diploma. I wish I could have asked more about that. So how pharmacists are viewed by the lay people. It's just kind of similar to the United States, that they are the easiest healthcare professional to access. There's pharmacies on every street, so it's very easy for someone to walk in and just ask the pharmacist some questions about a medication or disease state or anything. So, like over here in the States, it seems like pharmacists have a bit more of a negative light because, it's not done quick enough, or, the insurance and the price is wrong and all sorts of issues that we have here. They don't really have any of that because there's no insurance companies. It's pretty much all NHS. So in Scotland, they don't pay for medications. In England, they pay, I think, a little over £7, like 7.5 or something, for the medication, every single medication, regardless of what it is. So because of that, like, universalness and horrible part of our community setting that's kind of taken away, pharmacists have an opportunity to have a much more positive light. They recently started the minor ailment scheme, which is very similar to just like triaging patients and prescribing basic medications, which would basically be like our OTC and self-care. So I feel like pharmacists are viewed as knowledgeable healthcare professionals that have, they're very easy to access, especially now that pharmacists are becoming independent prescribers. and are having more of an active role in patient care and adjusting medications and ordering refills and stuff, their presence in the healthcare field is growing, and I feel like with that they're gaining more trust from the public. So my seventh and last learning objective is, are controlled substances and diversion as big of a problem in the UK as it is in the United States, especially in the state of Florida? So this was really interesting to me, as every single pharmacy that we asked about this is kind of like, why would that be a pharmacy issue? Because through the NHS, patients are required to register with a single general practitioner, and they agree basically to see that general practitioner. They can switch, but one guy kind of described it and basically said everybody kind of thinks about it, but no one ever actually does it. So it's very rare to see someone switch general practitioners. So, and in order to see any sort of specialist, you must go to your general practitioner first and then get a referral. So, you really can't see like a pain management doctor or multiple pain management doctors because you have to see your GP. The only time it would be an issue is if you were paying privately to see a specialist. Like, you could theoretically pay out of pocket privately to see a pain management doctor to then get a prescription, which then cannot be NHS. It has to be a private prescription, and then you'd have to pay for the medication. So it would just be a lot of money, and a lot of, like, that's just too much of a hassle for people to do. So because everybody must register with a general practitioner, can't really shop around for doctors, which is like a huge issue here in Florida. And so it's kind of up to the prescriber to determine the legitimacy of the prescription and the legitimacy of the claim. So they should be able to see most of the other medications that the patient is on. So the pharmacist, it's all out of their hands because it's taken care of further up in the chain, which I think is probably a better way to do it, because then we waste so much of our time dealing with this and we catch a lot of flack when really, we're not the ones writing these prescriptions, we're just the ones refusing to fill them. And then patients are asking us, well, why did my doctor even write it if you're claiming it's inappropriate and stuff? So it should kind of be a little bit further up the chain, I think, simply because it's a huge burden on pharmacies to deal with. So now I'm going to kind of go through the 9 course objectives. So the first one is engage with pharmacy students and faculty and other members of interprofessional healthcare teams to acquire knowledge about differences in culture and professional customs. So this happened basically every day we were in a pharmacy. We were, talking with the pharmacist that was showing us around, talking with amongst ourselves and with the students and people that were showing us around, and like asking questions and thinking critically and trying to just learn as much as we can about the culture and customs and stuff. So we learned a lot about the culture, not just through these pharmacy days, but through our weekends off when we would go on excursions. And when we were in Ireland, we went on a day trip to the Cliffs of Moher, and our tour guide sung us typical Irish songs. So that was just like a little bit of culture, and it was really cool. So we learned bits of culture, and we went on a trip in Scotland, all over the place, and same in England. So being able to see different areas of the country than what we were just visiting pharmacies in was a lot about culture. Professional customs. We talked a lot with different pharmacy schools about like how they teach pharmacy and kind of how they're changing. Especially at the University of Strathclyde, we kind of talked about how their students have very little experiential practice and how they're trying to move towards a model that has a lot more experiential practice integrated throughout, instead of just all being during the 2 pre-reg years. Demonstrate cultural competency with pharmacists and other healthcare professionals encountered in an international setting. So obviously this entire thing took place in an international setting. Cultural competency came a lot in hand when people kind of demonstrated their prejudices against Americans, or were saying horrible flaws about our system. We kind of had to like defend ourselves, but not in a way that seemed kind of attacking. It was more of like this is kind of how it really is. These are the facts about it, and trying not to seem defensive or offensive. So that was really like, and sometimes it was a bit more difficult than others. Sometimes people were generally curious and very receptive, and they were sharing all of their information about how their system works and how they practice pharmacy, and they were really interested in learning more about how our system works and how we practice pharmacy. So compare and contrast pharmacy education in the United States with pharmacy education in the program country. So we went to University College in Trinity College in Dublin. There we toured the pharmacy school, and we got to talk with some different professors and stuff. And basically the consensus is that pharmacy education in Europe, because it is a bachelor's degree, and then you do your one pre-reg year to kind of make it a master's, they only have 4 years of courses, whereas we have at least 5, probably more if you count the pre-pharmacy, any degrees pre-pharmacy. So their education feels like it was kind of crammed in, and so because of that, pharmacotherapy kind of got pushed back to postgraduate, like the clinical diploma I talked about earlier. So, and their education has a lot more of an emphasis on industry. In Ireland especially, they have the lowest company taxes, therefore 9 out of 10 of the major pharmaceutical companies are based out of Ireland. So, because of the heavy presence of industry in these countries, their education tends to have a bit more of an emphasis on industry. Even though I believe they said only 1 to 2% of their graduates actually go into industry. So I thought that was really interesting that they would have all sorts of analytical chemistry classes and synthesizing and heavy emphasis on doing a research project, which I think is really good. Research projects definitely would expand your knowledge and, learning a bit more about the scientific method firsthand and really investigating something very thoroughly. But I feel like some of those advanced analytical chemistry courses and stuff might not be as applicable as they think they are. Because, you graduate, and when do you ever need to know how to synthesize acetaminophen again? Or paracetamol, sorry. So, it seemed like it was necessary back in the day when, there was a lot more of an emphasis on graduating and going into industry, but now it seems kind of antiquated, but they don't really know where to put it. So, it was interesting. Similar for Ashton University in Birmingham, and Manchester University we didn't really see too much of. I meant talking with professors and students-wise. We were there for a CPPE day, which was really interesting to kind of see pharmacy postgraduate education. So there's CEs and courses like that. That was probably one of my favorite days just because it was so different than everything else. You visit a hospital and another hospital, and it's very, very similar. Obviously, every place has their own little ways of working and stuff like that, but the CPPE day was just so much different than everything else that we did. It was really cool to brainstorm and see these people who are very passionate about not only pharmacy, but teaching pharmacy and having their areas of it was a 2-hour CE course or an 8-week-long extended learning course, that someone can say, I want to be a mental health pharmacist, and I completed this training course online in mental health and how it relates to pharmacy, community pharmacy or something like that. So I thought that was really cool as kind of just seeing different opportunities that pharmacists would have to kind of advance their own education and kind of take their own initiative for it, especially with what they're kind of redoing the way that they redo the licensure and redo the not really licensure, what they call it, re-registration or something like that, renewing the registration. Kind of they're evolving their requirements for that. So the next one is compare and contrast the role of pharmacists in a variety of practice settings such as community, health system, ambulatory care, and industry. So we didn't really see any ambulatory care settings or industries. Actually, we kind of talked about ambulatory care, but like the majority of what we saw was community and hospital pharmacy. So in community and hospital with accuracy checking technicians, the pharmacists don't really have to, be back there checking. They're just doing the clinical checks, and then they can spend the rest of the time talking with patients or making adjustments and, doing other much more clinical things. And I think it's really an awesome thing that the technicians have had that opportunity for their own career advancement. So, you kind of elevate the technicians to have them at a higher level of practice, and then that frees up the pharmacists to be able to have a much more clinical emphasis when they practice. So I feel like pharmacists have a lot more of like a patient-centered focus there, and they do a lot more like direct patient interaction, especially in community when they're actually triaging patients and performing everything we learned in our self-care scenarios. They're actually doing that every day because the patient can't get their Sudafed unless they go through the pharmacist. We kind of talked about ambulatory care a little bit in that they're trying to do a lot more community outreach, especially at, I believe it was like Whittingham Hospital. They're trying to do a lot more like community outreach and just like community health screenings and stuff like that. And pharmacists can now be independent prescribers within their own area of their competency. So you can specialize in like diabetes or something and then work at a general surgery kind of area and see patients and tweak their diabetes medications, prescribe their diabetes medications, and help improve their diabetes care. So that's very similar to what my ambulatory care rotation was like through the VA. Adjusting insulin doses, adjusting warfarin doses, and being able to do that and write a prescription as an independent prescriber was really cool, and something that I think would be really awesome for us to do outside of the VA. Obviously, in the States, there's kind of the issue of us stepping on doctors' toes, whereas the NHS sees it as they can pay pharmacists less than they can pay doctors, so why not utilize pharmacists in that area? So recognize cross-cultural differences that impact a patient's belief about health and the treatment of illness. We didn't really talk about this as much because we didn't really get to talk to many patients. But one of the most interesting things that I learned about was because the NHS is free at the point of entry, they pay so much in their taxes that goes to fund the NHS, and whenever they need to access the healthcare system, they don't have to pay for it. Because of that, patients have no idea what their healthcare costs, which is simply unfathomable to me as an American who, you get your bill and you've got every single line. This is what service was, this is what you paid for it. This is the service, this is what you paid, this is what insurance covered, this is what's left at the end. So, because they kind of have no idea, they don't really know how to value it. You give a patient a medication, and regardless of what the medication is, they're paying nothing in Scotland or a little bit over £7.50 in England. So it's kind of like, no matter what the medication is, they don't truly understand the costs of it. And if they don't really understand the cost, they don't really assign a value. And especially if the medication is free, it's so easy to say, well, they gave this to me for free, so it obviously must not be worth anything. I'm not going to take it. And pharmacists expressed that was kind of an issue with the patients, that they just don't understand the true value of their health care. So demonstrate professional attitudes and behaviors that characterize a professional pharmacist. I mean, we did this everywhere we went. We dressed professionally. We didn't have our white coats, but, you know, dressing up in a button-down shirt and nice slacks and dress shoes, and, you know, just being quiet and respectful and asking questions. You know, professionalism is such a kind of vague term, but, you know it when you see it, and I feel like all of us behaved very appropriately. You know, we didn't use inappropriate language or anything, and it was just, I felt like we had a very respectful relationship, and that these people that we visited were so eager and so generous to share their time and their knowledge with us about how their system works, and they were equally as curious to kind of see what we had to offer and how our system works, and it is very kind of give and take and very equal. So personal development expected of pharmacy student by showing initiative, confidence, and adaptability. I mean, I feel like I've shown kind of confidence and adaptability and being able to, like, very much step out of my comfort zone and kind of start these conversations with these people. I'm very much an introvert, and I love hanging out by myself, and, you know, I can totally be quiet and a wallflower, but I feel like especially at the last hospital that we saw in London, I think it was like Whittingshire or something like that. You know, just being able to like socialize with these pharmacists and kind of talk to them, like I said, on a very equal basis, like that really took me out of my comfort zone, but I was, you know, confident in doing it. I knew what I was talking about. I knew, you know, how to convey the information. So I felt like that was a really kind of growing point for me, was that I can be social. I can be the kind of outgoing person when I need to be. So demonstrate self-directed learning abilities during the program by identifying needs, developing a plan to accomplish these needs, and conducting a self-assessment. I kind of already done that. I went through what my goals were. I made sure to, you know, keep them in the back of my mind when I was talking to these pharmacists and asking them, like, what opportunities does a pharmacist have in this area? And, you know, trying to constantly, you know, think about that, and kind of, whenever I was doing my daily journal, kind of be like, oh, that's what I learned about today. That was in my self-directed learning. So I felt like I did a pretty good job of that. And the last one is exhibit little L leadership when interacting with international faculty, students, and practitioners. This kind of, I feel, really goes back to the professional pharmacist thing of just being respectful and, you know, being comfortable and being a leader. You know, we're representing not just, you know, University of Florida or College of Pharmacy or anything, but we're representing the United States. You know, I know they've probably talked to Americans before, but this is a unique opportunity where they could talk with us as professionals and as Americans. So, you know, we're representing so many people, so it's our duty to do the best job that we can. So I like to think that I had accomplished all 9 of these, in addition to completing my 7 learning objectives. So with that, I have nothing really else to add other than that I really enjoyed the trip. I learned so much, a lot more than I even expected to, and just little things. But I do love being back home. So I feel like this trip will definitely be like an integral part in my professional development, and, you know, really learning that we have to be active in our profession in order to kind of steer it in the way that we want to go. So thank you for watching all 29 minutes of this. Bye.